Okay, the next question is question number 31. This is regarding caducil. This is regarding caducil. And the answer is D, that is all of the above. This is cerebral autosomal dominant arteriopathy with clinical infarct, subcortical infarct and leukoencephalopathy. Remember that it presents as multi-infarcts, MI, multi-infarcts with dementia, predominantly white matter changes. It is autosomal dominant in inheritance, and patients do have migraine with sensory deficits. Question number 32 is regarding CT scan findings in acute stroke. That the maximum enhancement in CT scan is seen in how many days? The answer is D. Remember, early stroke is best captured by MRI brain, particularly if it's a stroke protocol or diffusion weighted images. Diffusion weighted images. In fact, diffusion weighted images may capture acute stroke within hours, whereas CT scan is good to rule out hemorrhage. Because ruling out hemorrhage is important, because so that you can initiate antiplatelet or thrombolytic therapy from the word go. Question number 33, Dejeron-Roussy syndrome. It is seen in definitely thalamic lesions, and what happens is there is thalamic hemorrhage. Patients developed spontaneous pain and paresthesia over the opposite half of the body. Nothing to explain in particular. Answer is C. Question number 34. Jackson sign is seen in, the answer is D, hemiplegia. What happens is, suppose person has left sided hemiplegia. So, if he is respiring normally, the side over the hemiplegic side will be seeing a more better respiratory muscles movement as compared to the muscles on the normal side. That is the what you call as Jackson sign. However, if you ask patient to breathe forcefully, this paradoxical motion will be suppressed. Next question is 35. What is A, B, C, D to score? For which of the following it's done? It's done for TIA and stroke. Answer is A. More the score, higher the risk. We have various variables in this. We have various variables such as age, blood pressure, clinical symptoms. You have TIA duration and diabetes. The score is, highest score is 7. Question number 36. Berry aneurysm defect lies in degeneration of internal elastic lamina. Answer is A. See, what happens is, this is an artery, this is internal elastic lamina, this is the outer covering, and this is the fibrous tissue. All right, this is the cavity where blood flows. What happens in barrierism, that here you have a defect like outpouching, and the internal elastic lamina is not present. So, basically the only protective covering is the fibrous structure which is there. This is the formation of barrierism. So, primarily there is degeneration of internal elastic lamina. Question number 37. This is regarding hypertensive male presenting to you with sudden onset severe headache, vomiting and neck pain. So, three things are there: sudden onset headache, vomiting and neck stiffness. The obvious answer is subarachnoid hemorrhage. Why not ICH, intracerebral hemorrhage? Why not ICH? Because neck stiffness favors subarachnoid hemorrhage. Headache and vomiting can be there in intracerebral hemorrhage too. Why not meningitis? Why not meningitis? In meningitis, sudden onset headache is not prominent, neck stiffness is prominent, fever is prominent, photophobia is there, signs of meningisms are there, vomiting will be there. So, again neck stiffness in meningitis. So, in this question the most plausible diagnosis is subarachnoid hemorrhage because of ruptured aneurysm. The answer is B. Question number 38. This is regarding a old diabetic female who comes to hospital with right sided weakness, slowly progressive, with speech difficulty and fundus examination showing papilloedema, and 2 months back she had a fall in a bathroom. See, so this is a classical example of old age female with fall, with slowly progressive neurological deficit. This is a classical picture of extra axial neurological involvement. That is EDH, SDH, extra axial. So, the answer is D, left chronic subdural hematoma. Answer is D. Question number 39. This is regarding a healthy woman complaining of severe excruciating headache with transient loss of consciousness. See, whenever you have new onset worst headache, plus LOC, always remember subarachnoid hemorrhage, and the best modality for diagnosis of subarachnoid hemorrhage is a plain CT brain, and the best diagnosis to confirm subarachnoid hemorrhage is LP. So this is a screening test, plain CT brain. Even this can miss, but lumbar puncture is the gold standard for diagnosis of subarachnoid hemorrhage. So the answer is subarachnoid hemorrhage is there. So it's a CT scan without contrast. Answer is A. Answer question number 40. What is Chang classification? You have to remember it as such. Chang classification is for retinoblastoma. I'm sorry, Chang classification is for medulloblastoma, not retinoblastoma. I'm sorry, it's for medulloblastoma. Question number 40. Remember, medulloblastoma is one tumor which is highly radiosensitive. Next question is question number 41. Temozolomide is used for, it's a new drug for brain tumor basically. We have to remember it as such. Temozolomide is used for brain tumor. So, question number 41, answer is C. Question number 42. True regarding upper motor neuron with seventh nerve paralysis. Obviously, if you have upper motor neuron and this is the face, this is upper motor neuron, so whenever you have a lesion which is upper motor neuron here, so you have a bilateral representation. This is, sorry, this picture is not correct. The face, the lower part of the face, the upper part of the face is basically spared whenever you have an upper motor neuron lesion, UMN lesion. This upper part is spared, whereas in LMN lesion everything is gone, upper part and lower part. Upper part you have representation from both nuclei, both superior nuclei. So answer in this question is D. Answer is D. Question number 43. A male presents with pain, numbness, impaired sensation over half of face with ataxia and nystagmus. This is a classical example of lateral medullary syndrome. So the answer is pica. Answer is pica. 43. Answer is B. See, we have to remember it by heart. Medial medullary syndrome, lateral medullary syndrome, they are very important and often being asked in various examination. Criteria used to diagnose multiple sclerosis. Next question, question number 44. It is McDonald criteria. So answer is D. Question number 45. Which of the following is a non-ergot alkaloid? Pramipexole, rotigotine, propirenol. All the drugs are used for Parkinsonism and all are non-ergot alkaloid. So, answer is D. Next is question number 46. Answer is B. Supranuclear palsy, also known as Steele-Richardson syndrome. Supranuclear palsy, Steele-Richardson syndrome. Usually it occurs in males, middle-aged males. Whenever they try to look downwards, there is a vertical gaze palsy, there is axial dystonia, and because of that there is frequent falls, right. Question number 47. Which of the following drug is used for neuroprotection for Parkinsonism? See, bromocriptine, carbidopa, ropirenol, they are drugs used in treatment of Parkinsonism. They are not neuroprotective. So, the answer is coenzyme Q. Answer is D. 48. Shy-Dagger syndrome in Parkinsonism is Parkinsonism plus obviously autonomic neuropathy. There is no doubt about it. Autonomic neuropathy. Huntington's disease is due to the loss of, see, Huntington disease is basically an autosomal dominant disease, occurs in middle-aged male. It is potentially lethal disease, and basically there is cholinergic and GABAergic neuronal loss in striatum. So, there is no medical management as such for this disease. It is a difficult disease to manage. So, the answer is 49. Answer is D. Question number 50. Increased level of which of the following is associated with Alzheimer's disease? It is homocysteine. Answer is C. Question number 51. Again, hardly anything to explain, that the normal level of glucose levels of glucose level in CSF is equal to how much of the plasma? It is 2/3 of the plasma glucose. Always remember that. The answer is B. Question number 52. A person has focal seizure, MRI show frontal and temporal enhancement, most probable diagnosis. Remember, whenever you have focal enhancement, on MRI plus clinical features of encephalitis. It is not encephalopathy, and it is encephalitis. What is the difference between encephalitis and encephalopathy? Encephalitis is inflammation of brain parenchyma. Encephalopathy is clinical manifestations of global neurological dysfunction without pathological involvement of brain parenchyma. Say for example, CO2 narcosis, you may have features of encephalopathy. In patients of hepatic encephalopathy, there is no problem in the brain, it is because of the ammonia you have hepatic encephalopathy. So, clinical features of encephalitis with focal enhancement on MRI, always remember herpes simplex virus. In fact, this virus can cause florid hemorrhage, florid intracerebral hemorrhage in patients of acute viral encephalitis. So, the answer is B. Answer is B. Question number 53. Inclusions in oligodendrogliocyte is a feature of progressive multiple encephalopathy, that is because of JC virus. Answer is D. Question number 54. A 60-year-old man complains of progressive dementia for past 6 months, now with suddenly diffuse jitteriness. See, dementia with bilateral sharp bipolar spikes in EEG. So, dementia which is progressive, new onset, is not relatively fast progressive, and new onset dementia in a middle to elderly male with EEG findings are classical of CJD. It's very difficult for me to pronounce this CJD, always very difficult. So, the answer for question number 54 is B. Question number 55. It is regarding drug interaction between two drugs, carbamazepine and phenobarbital. Remember, phenobarbital is an enzyme inducer and so do carbamazepine. So, they can decrease each other's level. So, we have to be cautious. So, the answer is decrease carbamazepine level. Answer is B. Question number 56. Which of the following drug is a potassium channel opener? Answer is retigabine. B. Retigabine. Just remember this as such. Question number 57. Mesial temporal lobe epilepsy. This is a repeat question in this question bank. It requires surgery. It's refractory to the medical treatment. So, answer is B. Question number 58. A 65-year-old man presents with anemia and posterior column dysfunction is likely the cause. See, posterior column dysfunction, remember B12 deficiency, HIV myelopathy, Friedreich's ataxia and tabes dorsalis. These all will cause posterior column dysfunction. Vitamin B12 deficiency, HIV myelopathy, Friedreich's ataxia and tabes dorsalis. So, the answer is B. Question number 59. Descending paralysis. See, descending paralysis can occur in diphtheria, polio, botulism, porphyria, all of the following. However, the pupils which are non-reactive favors botulism. So, the answer is B. Remember, in polio, pupils are spared, so do the case with diphtheria and so do the case with porphyria too. Question number 60. There is ascending flaccid paralysis in a child with CSF showing albuminocytological dissociation. Albuminocytological dissociation means whenever there is increase in cells, there should be a corresponding increase in protein or albumin. However, whenever you have GBS, you have practically no cells, so there is no infection or inflammation, but there is increase in protein. So, this is known as albuminocytological dissociation. And what is the best treatment of modality for Guillain-Barré syndrome? It is IVIG and plasmapheresis. So, it is D, IVIG. Question number 61. Myasthenia gravis is associated with obviously decreased myoneuronal junction transmission. See what happens in myasthenia gravis. This is a synapse. These are the acetylcholine receptors. The number of these receptors, they decrease because of AChR antibodies, acetylcholine receptor antibodies. So, what happens is whatever acetylcholine is there, it is ineffective. So, the transmission of impulse from here to here is impaired. We obviously cannot regenerate these post-synaptic acetylcholine receptors. So, what we do is we increase the level of acetylcholine by drugs, so that more acetylcholine acts on those existing receptors. So, the answer of question number 61 is D. Question number 62. This is regarding bilateral intermittent ptosis, proximal muscle weakness, easy fatigability. So, again it goes in features of myasthenia gravis. Now, remember myasthenia gravis, two tests are there: repetitive nerve stimulation test and single fiber electromyography. Single fiber. This is the best test to diagnose. However, it is more difficult, so this is easily available. Even repetitive nerve stimulation test is sufficient to diagnose myasthenia gravis. However, this can be false negative sometimes. So, single fiber EMG becomes the gold standard for diagnosis of myasthenia gravis. However, it requires a expert technician or a doctor to do it. So, availability of single fiber EMG is limited. So, answer of question number 62 is single fiber EMG, that is D, EMG. Question number 63. A young girl has difficulty in combing hairs and climbing upstairs. So, proximal muscle weakness. She has Gauber sign positive with rash over metacarpophalangeal joint. So, next appropriate. So, the patient has myositis. The patient has myositis. So, best investigation for myositis is creatinine kinase. So, myopathy or myositis, the best diagnostic modality is creatinine kinase. So, answer is C. 64. Question number 64. Which is not a feature of dermatopolymyositis? As I already said, you have a CPK which is high. So, if CPK is normal, this becomes a automatic answer. Answer is D. CPK can be erroneously high if you have done an EMG in a patient who is having suspicion of myositis or myopathy, because that needle in the muscle can cause erroneous levels of high levels of CPK. Any muscle injury or trauma can cause high levels of CPK too. Question number 65. Progressive atrophy of and weakness of hand and forearms. So, that is lower motor neuron weakness, and spasticity of the leg, that is a upper motor neuron sign. So, whenever there is a mixing of LMN and UMN, the diagnosis is amyotrophic lateral sclerosis, ALS. So, answer is B. Question number 66. A 30-year-old man has MR and AF and comes to the hospital with syncope and bradycardia. So, MR plus AF comes to hospital with decreased heart rate and syncope. So, syncope is due to decreased heart rate. This can be related to this. Now, decreased heart rate cannot be because of atrial fibrillation, cannot be because of MR. So, there must be a drug which is given. So, drug which is commonly given for AF is digoxin. It will decrease the heart rate, all right, and decreased heart rate will give rise to syncope. So, the patient has digoxin toxicity. Answer number is A. Question number 67. An unconscious patient is brought to the emergency with suspected cervical cord injury. See, whenever you have a cervical cord injury, it is known as spinal shock. So, tones, be it a bladder tone, be it a rectal tone, will not be increased. Bladder will be flaccid. So, there will be retention of urine. Similarly, sphincter, rectal sphincter will be loose. There will be incontinence of the stool. So, answer is B. Question number 68. HLA-B5. HLA-B5 is classically associated with Behçet's disease. So, just remember it as such. Answer is C. Question number 69. All are true about synovial fluid. See, it is synovial fluid is secreted by type B synovial cells. Okay, so except the answer is A. Question 69. Answer is A. It is type B cells which secretes. Question number 70. It's about erosive arthritis. The answer is very clear. It is SLE. SLE is non-erosive. Remember, it is non-erosive. Osteoarthritis, rheumatoid arthritis, psoriatic arthritis, they are all erosive arthritis. Whereas SLE, it is non-erosive. So, answer is A.